This is another video in the series on stem cells. It's a review article. It's not a heavy academic article, but it's got some good information regarding knees. Here's the title: Biological Treatment of the Knee with platelet-rich plasma and bone marrow aspirate concentrate. So those are the two most popular methods of quote stem cell end quote treatments for the knee, and the knee is the biggest joint out there right now for stem cell treatment. The journal, again, is not one of the world-class journals. Maybe if you're from Scandinavia, you would think so. It's the journal of the Nordic Orthopedic Federation. Two basic centers, one in Vail, Colorado, and one in Oslo, Norway. I obviously don't know any of the authors, but I'll put the link down below the video. Now here's a few key things on it. As they point out, knee injuries are very common. They're a common source of disability. We've got an aging population. As that happens, knees don't kill you. You live with it, but it's like stroke. You live with it for decades and decades, and it's a common source of disability. Yet we're getting more and more demanding in our desire to live a non-disabled life. So again, it's a big deal. In which country? Scandinavia. So the three Scandinavian countries, I guess. The cost is $462 billion with a B for knee replacements alone. It doesn't include lost work time, disability costs, things like that. A couple of other ways of looking at prevalence of knee injuries. It's 2.3 knee injuries per 1,000 people, and 6 knee injuries per 1,000 ER visits. Now, here's a key term, and you'll hear this over and over and over again. And did I say it's not that simple? You will hear themes, but you need to understand. Again, if you're looking for a 30-second video, this is not the place to look for it. I go into detail on science. Here's a theme that you'll hear multiple times: limited, strong evidence. What they're saying is there's a lot of hope. There's a lot of evidence out there that people got huge improvements with these techniques. But it's still, there's some tinge of emotion to it. And the information there's other sides to this story. Let me just put that way, and we'll get into the details later. First, let's talk about platelet-rich plasma. What is that? That's one of the two major methods that we talked about that are being used for knees right now. Basically, with platelet-rich plasma, you draw blood, you spin it down, and you get what's called the buffy coat. The buffy coat is mostly platelets and white blood cells. When you spin blood down, that's what it looks like. The red blood cells are here, the plasma is here, and this is what they're taking: platelet-rich plasma. Now, what's the other one look like? Well, it is, well, let me show you this first. This is what it looks like if you're in the OR. You don't have to have all that back there. That looks like MRI mechanism. But this is a patient. This is the doc, and this is where this is the patient's pelvis. Now we'll show the diagram so it makes a little bit more sense. The doc is going into the bone of the pelvis and getting bone marrow. the advantage to that is it gets what's called potent cells, progenitor cells, basically cells that have much more of a stem cell type of perspective. What you get with platelet-rich plasma, with platelets, it's not that you're looking for the platelets, you're looking for growth factor inside, which resides inside the platelets. So with PRP, platelet-rich plasma, you're getting growth factor. With the bone marrow aspirate, your concentration, you're getting some progenitor cells. Okay, so platelet-rich plasma has it's expanded recently. They went from, originally it was just more platelets than usual. Now they've got a cut point, they've got a standard, greater than 1 million platelets per milliliter, or 5 times the normal concentration. And again, as we said a minute ago, what you're looking for there is not platelets itself so much as the growth factor inside the platelets. I think we showed this another version of this picture a minute ago. This is the red cell layer, the plasma, and then the buffy coat that you're looking for. Now, again, they've used, if you start to look at the studies that are out there, you do get significant improvement, or it appears to be, but maybe a short time, maybe 6 months or so. That led to a further delineation in detail here. They started saying, you know what, there are white cells in this buffy coat as well. And the white cells maybe are increasing inflammation. Inflammation is the last thing that we want in terms of this type of growth and healing process. So let's take the the white cells out. I'll do a separate video on a couple of studies with that. There's been a meta-analysis of that, and it looks like that might have some hope. There's a couple of terms for that. Instead of just PRP, it's called P-PRP, purified protein-rich plasma, or LP PRP, which would stand for leukocyte poor. Leukocytes are white cells. LP PRP. So again, as you see, we're getting deeper and deeper in terms of trying to figure out what really works here. They've done it with anterior cruciate ligament. It's not just cartilage. Cartilage is maybe one of the most common injuries that we're doing this for, or that this is being done for. I'm not doing them. Actually, I may end up working with a group that's starting to provide these. In terms of doing some of what I'm doing the lit review, helping guide some of the development. Now, again, when you start looking at it, the outcomes, significant promise for improvement, but with tendons, with cartilage, there's a paucity of information, and we need to consistently use methodology. Again, you're going to hear that over and over and over again. Now let's look at BMAC, bone marrow aspirate concentration. As I mentioned before, what you do, the doc goes in, pulls out bone marrow, spins it down. So this is minimally impacted materials, minimally processed. But what you're looking for is MSCs, mesenchymal stem cells. Those are the stem cells that I was talking about a few minutes ago, where you actually have some progenitor component there. In other words, they can differentiate into other cells. Hopefully cartilage cells. Now, there's another problem with this, though. In this same layer with the MSCs, you get other white cells, leukocytes, monocytes. Again, those cells that could increase and have shown to increase, have been shown to increase inflammation. So that's some of the story there. We have what's called IL-IRA, interleukin. There's some different factors that get a little bit beyond the scope of this video, which do appear to be beneficial in terms of helping move that biological healing process forward. Nothing else there on that page. I've got just a couple of other pages. For those of you who are still hanging in there, thanks for your interest. And I think just a couple of more facts here. As you start looking at the literature, you've got some studies where you've got an improved function and decreased disability 1, 2, even 5 years later. Then you go down and you look at other studies, and in some other studies they actually did, they had 2 knees, same patient. They blinded the patient, and I don't know if they blinded the doc to this or not, but they blinded the patient to this. So this, you would think, would be very, very helpful in terms of teasing out some of this emotional component of, yeah, it really, really helped. In the only study that they saw regarding this so far, there was no difference. In other words, they injected one knee with saline, normal saline, the other knee with BMAC, bone marrow aspirate concentrate. Got the same results in the patient on both knees. Very disheartening. So again, as a summary, this is promising. These are not my words; these are their words, but I agree with them 100%. This is very promising. But not convincing yet, not conclusive. We still have a lot of those signals, like the last one I discussed in the literature, that some of this may be just hype. There's a problem with conclusive documentation, and one of the major problems that we're seeing now is there are so many new variations in what we do. One thing I haven't mentioned yet is the addition of matrix, the addition of things like hyaluronic acid to the mix. Hyaluronic acid is some stuff I'll talk about later, but cartilage, these cells, these progenitor cells, if they're going to be laid down, they need a matrix to attach to. So you're talking about adding different versions and concentrations of a matrix. You're talking about different types of cells. You're talking about progenitor cells. You're talking about very confusing. And again, it's not that simple.